Dr. Joel Shenker is a cognitive neurologist at MU Health, and he's a specialist in such things as memory, apathy, and behavior in Parkinson's. So, of course, that rounds out the team of all of the people we've talked about today. As we all know, there is a lot more to Parkinson's than just motor skill symptoms. As the disease progresses, we become concerned about some of the non-motor issues, such as increasing cognitive difficulty. We've heard from Dr. Shenker before, and we always learn something new, so let's welcome him.
Thanks. Thank you. Today you've been hearing a lot about Parkinson's disease and some of the different problems that Parkinson's can involve. And of course, we all know about the motor symptoms of Parkinson's disease: slowness and stiffness and tremor and walking troubles. But it turns out that there are a lot of problems that have nothing to do with movement in Parkinson's disease. And as Patsy just alluded to, many of these become more clear as the disease progresses, but at least in a subtle way, these things are actually present even early on in the disease. It's estimated that compared to people of the same age, people with Parkinson's disease are 4 times more likely to have many of these non-motor symptoms, which include problems with thinking and cognition. So I want to spend some time today talking about why it is that non-motor symptoms, and especially cognitive ones, occur in Parkinsonian diseases. I want to try and give us a way to try and understand how these happen, why they come about, and what exactly they involve. And I want to spend about half the time or so talking about what patients and families and caregivers have taught me about what kind of coping skills and responses seem to work or help. Now, I'm going to use an old metaphor. If you have a hammer, everything looks like a nail. The point being, of course, that your perspective changes a lot about what you see. So I'm going to suggest that we take the perspective that I use when I'm seeing patients, called behavioral neurology. So for the last few decades, I've lived in the green part of this Venn diagram, trying to understand the overlap between how the brain works, how the mind works, and how behavior works. So we're going to try and focus on Parkinson's disease and Parkinsonism more generally from this perspective. So we always begin in neurology with a dead white male physician from the 19th century. In this case, it's Dr. James Parkinson, who was not a neurologist. Parkinson was a surgeon. And he wrote this book in 1817 called An Essay on the Shaking Palsy. It was a case series of 6 people. I don't know why I would like this to say 6 people. It's the new math. It was a case series of 6 people. And interestingly, only 3 of the people were people he had met. 3 of them were people he just saw walking, in the streets. But the clinicians of the day were very detail-oriented. They did an excellent job of describing the phenomena, the experiences that people have as they go through different diseases. And we still use the descriptions Parkinson gave so well and so eloquently to understand the basic 4 cardinal symptoms that occur in Parkinson's disease. This is what we teach the medical students and the resident physicians who were training in neurology. We expect that in Parkinson's disease there is slowness to movements, that muscles become stiff, that as a result, the person's posture, their walking, and their ability to stay erect on 2 feet becomes less stable, and the classic tremor, usually in the hand. These 4 features, these motor features, are cardinal. They're central to Parkinson's disease, and we usually see some variation of most or all of these 4 features in the disease. And normally when people think about Parkinson's disease or any of the Parkinsonian diseases, they think about these four things. Why does it occur? It occurs because, I want to teach a little bit about the brain here. It occurs because these brain structures called the basal ganglia start not to work well. They start to degenerate. Instead of generating, they're degenerating. They're fading away. They're wasting away. In this cartoon, you can see the basal ganglia are kind of buried deep in the brain. And in a sort of cartoonish way, when you look at textbook descriptions of the basal ganglia, it's really hard to get a good sense of where they are and what they look like. I always think of the basal ganglia as kind of like, you know, those toys you put together for the kids, and you put the part A into slot B, and it takes you an hour and a half, and when it's done, you've got 3 or 4 parts left over. And you say, well, we'll just stick them in somewhere, you know, and the kids won't notice. And that's what the basal ganglia always felt like to me. God was putting together a brain, he got some parts left over. Oh, I forgot we got to put that in. Well, let's stick it in somewhere. When this part of the basal ganglia degenerates, the substantia nigra's pathway into the striatum, when that pathway gets affected, and when that pathway starts to fade away, and more than about 2/3 or so of it is gone, that's when we start to see some of the motor symptoms of the disease. What does it do? The fundamental problem that occurs when the basal ganglia get damaged in this way is it's hard to start and stop movements. Both. It's hard to start movements, it's hard to stop movements. Every muscle in the body has to be told what to do. And if I want to, for example, flex my elbow like this, not only do I have to activate the biceps muscle, but I have to deactivate the triceps muscle, the muscle that would have made my arm go like so. In Parkinson's disease, when the nigrostriatal pathway is damaged, all the muscles in the body are all being told to do something kind of all the time. Shouldn't do that. We no longer select one muscle against the other as well. The result being that it's hard to make movements. It's hard to start them and it's hard to stop them. And so the human activities that get affected by these are the human activities that involve the most amount of starting and stopping, like walking. It turns out that the way we humans walk with just 2 limbs is really complicated. There's a couple of 100 different muscle movements we have to make to execute this incredibly complicated task of walking. So each one of those movements is not timed really well. It's not started well, it's not stopped well. When we make facial expressions, all the tiny little minute expressions of the face to communicate emotion or to communicate other kinds of information. Lots of starting and stopping, and so you get the classic so-called masked faces, where the faces kind of look like a blank stare like this. The vocal cords have to move back and forth very, very rapidly to make our voices, and those don't make those movements the way they should. And so the voice changes. Taking a pen and writing with a pen requires a lot of very fine, minute movements of all the intricate muscles of the hand. And those don't get made and started and stopped as well as they should. And so handwriting becomes very slow and hence very small because it's hard to make those wide, excursive movements. This is part of why the motor symptoms of Parkinson's disease occur. Now, to understand how thinking and behavior changes, I need to teach one more important point, and that is this. Brain areas combine in large networks to control human functions. A common misperception is that the brain has centers for human activity. It doesn't. The brain has networks, but not centers. There's no one tiny little part of the brain that controls movement. There's no one part of the brain that's responsible for memory or language or any one specific thing. But by having different parts of the brain do different things, and by having those different parts work together, the network of interactions of those parts produces those human functions like language and memory and movement. So a corollary to that, if we think about that widely dispersed network of the basal ganglia with all these different parts that are in lots of different parts of the brain, these brain areas do participate in motor function, but they participate in other things too. They are not responsible for movement. They are simply parts of the brain which movement particularly depends on. But other parts, other networks of the brain also depend on basal ganglia for certain things. This is a diagram I use when I'm teaching the first year. You're not going to have to memorize this. When I'm teaching the first year medical students, I give them this diagram. This is actually a simplified version. There's an even more complicated one people like Dr. Siddiqui and Dr. Shah could teach us. And I'm not going to make you understand all that, but I took that slide and this one from a lecture I give to the first year students to make this point. What exactly do the basal ganglia do? Well, what they really do is they enhance this concept called signal-to-noise ratio. What do I mean? So graphically, I've put here a whole bunch of blue circles. And can you tell that most of the circles have an X in the middle of them, right? Can you see that one of them has a Y? It's a little hard to tell, though, isn't it? And if I go like that, it's a lot easier to tell. What I've done here is to enhance the signal-to-noise ratio. And that's what the basal ganglia do. You see, every movement that you would like to make is programmed. Your brain has a set of instructions for that movement. But it's got that little packet of instructions right next to another packet of instructions for another kind of movement. And all these different movements are represented in the brain. And somewhere in the brain, the decision is made, we want to make movement 47. Not movement 46 or movement 48, we want to make movement 47. What the basal ganglia do is they make movement 47 much more clear, much more apparent. So it's contrasted from the others. That signal-to-noise ratio has changed. You need that in order to execute the movements you want to execute and not to execute the other ones you don't want to execute. So a person with Parkinson's disease, in a sense, is trying to execute all their movements a little bit, not just the one that they're trying to select. So if that's what's happening in a motor way, if it's hard to start and stop movements, actually, the basal ganglia are needed to select anything. And this is why Parkinsonian problems affect thinking and behavior. All the different thoughts you want to think, all the different thoughts you want to not think, the ideas you want to attend to, the ideas you want to ignore, the hobby you want to pursue, the book you want to concentrate on, the new idea you want to present at a meeting or in a conversation. You have to select these. And you have to, therefore, not select all the other competing thoughts and ideas and behaviors. And the basal ganglia help with that, too. So when the basal ganglia change, when these parts of the brain that affect your motor systems change, they also can have the capacity to affect thinking. As a result, a common problem that we see in Parkinsonian diseases is apathy. It's hard to select the next thing to do. It looks like the person has less interest, like the person has less initiative. In a way that's accurate, but in a way that's not quite fair. Because the part of the brain they would use to generate interest and to generate activity is not doing what it needs to do for that to happen in quite the same way. As a result, a person with Parkinsonism might appear to have less motivation, less drive, less get up and go. They might have less what's called executive function. Executive function is a metaphorical concept in neuropsychology. If you think about What does the executive of a company do? In a sense, the executive doesn't do anything. The executive sits in an office. The executive isn't the person who's on the factory assembly line and putting together a product or doing the entry-level hiring and firing or going out and selling things. The executive makes strategy. The executive decides when to change the momentum of what the company is doing. The executive puts together all the pieces and says, okay, guys, go to it. So metaphorically, the brain provides us with the capacity for executive function as well. The ability to impose your will on what to decide, to say, do, think, or feel next. That refers to executive function. And executive function requires being able to select something and deselect other things. And with poor basal ganglia function, executive function can be impaired. As a result, it's harder to multitask. It's harder to plan things out. It's harder to come up with good strategies. A person might become they might pick out strategies that are bad ones. They might blurt out things or say things or select things that maybe aren't quite the best choices. Or they just might not do much of anything. And a very common feature as a result of these kinds of difficulties is that thinking and behaving slows down. It's not just that movements are slow, thinking is slow. The medical word we use when people have slow movements is bradykinesia. A word that we might use for this is bradyphrenia. Bradyphrenia, like schizophrenia, but brady, slow. Now, another reason why we get a lot of behavior and thinking changes in Parkinson's disease is because it's more than the basal ganglia. All I wanted to do on this slide was to show you graphically that more and more of the brain gets involved. So in the early stages of the disease, we often see just involvement in the lower brain stem. And then as the disease progresses, more and more and eventually large amounts of the brain get involved. It doesn't stay confined just to the basal ganglia. In fact, there are many changes in the body, in the gut, in other body systems as well. So that there are many things that underlie some of the symptoms of Parkinson's disease, not just that tiny little focused, discrete change in that one pathway of the brain. So because of this, we have a lot of non-motor symptoms, and these include, for example, depression. Now, depression is a really big and really common and a really unsurprising part of Parkinson's disease. One reason, of course, is it's not fun to have Parkinson's, and so that can be depressing. But there is something about how the brain itself is changed that makes depression in a primary sense more likely to. And that's treatable, depression is. Many times patients with Parkinsonian diseases have hallucinations. A hallucination is a sensory perception. You see something, you hear something, you feel it, but it's wrong. So if you see an elephant on this stage, there's not one here right now. If you see an elephant on this stage, that's a hallucination. This can occur in Parkinson's disease, as can delusions. Now, I'm making the distinction here between delusions and wrong conclusions. A delusion is a fixed, false belief that really you should know isn't true. It's not true. You think that you're a Martian sent to invade this country. If you think that thought, I'm going to take the leap of faith that that's probably a wrong thought. If you think that, that's probably a delusion. Okay? But it's also the case that some people, as they get cognitively impaired, conclude things that are wrong. And I'm not quite sure we should always call that a conclusion. If you're forgetful, and you come home and you put your wallet on the table and you go into the kitchen to get something to drink and you come back and your wallet's gone, you say, well, who the hell took my wallet? If this happens often enough, you may say, well, gosh, there must be people breaking into the house taking my stuff. And at some level, that's just a conclusion. That's not necessarily a delusion. It's like the old joke, if everyone's out to get you, paranoia is just good sense. Sleep changes often occur in Parkinson's disease. The tendency to move around during the night. Sometimes people will move as if they're acting out dreams while they're still asleep. This can disrupt not only their sleep, which has daytime consequences, but also can make them tired and fatigued during the day. So these are examples of a lot of non-motor things that can occur in Parkinson's disease. Now, I want to end this part of our time, before I go to some things that I think might be helpful, by defining a few terms. So first of all, we need to define the word dementia. It's important to point out that dementia is not a diagnosis. Dementia is a word that simply refers to a set of symptoms. So if I say someone has dementia, this is all that I really mean. I'm meaning they have a clinical state. It's a description of where they're at, of what they're experiencing, that is abnormal, that is acquired, involving multiple aspects, not just one, of decline in their thinking, in their cognition. It's caused by a brain problem, it's going on for a while, and it has functional impairment. These 7 things are needed for us to use the word dementia. So all we're saying when we say someone has dementia is they're having these features. We're not saying why. You're allowed to have dementia because of a rock that hit your head. You're allowed to have dementia because of a stroke. You might have dementia because of Alzheimer's disease. You might have dementia because of a Parkinsonian disease, or any of 100 or more different things that can cause dementia. Which then begs the question, well, what if all 7 don't fit? What if we say, gosh, the person has an abnormal, it's not expected, it's not normal, acquired, it's not their whole life that they've been this way, it's acquired, it's new to them, decline in several aspects of thinking, it's going on for a while, it's from a brain problem, but they're functioning. They can write their checks, and I don't know if even people write checks anymore, but they can pay their bills, they can take their medications, they can manage household affairs, they're functional. What do we call that? Well, the phrase that we use for that is called mild cognitive impairment, MCI. The mild cognitive impairment doesn't necessarily mean that your symptoms are mild, it's the phrase. And we usually use it when someone doesn't meet the definition of dementia because they're still functional. Depending on the cause of MCI, of mild cognitive impairment, many people will worsen over time, and we think that that's at a rate of about 15% a year. So that an MCI patient a year later has about an 85% chance of still being MCI and not dementia. But understand, we're talking now just about descriptions of a clinical state. We're not giving a diagnosis. There are many, many things that could cause either dementia or MCI. 2 of them are entities you may have heard of, Parkinson's disease dementia and dementia with Lewy bodies. And there's arguments about whether we should really think of these as 2 separate problems or the same problem but evolving differently in person A versus person B. In a person who we say has Parkinson's disease dementia, they have the motor Parkinsonism for at least a couple years before a dementia evolves. And the people who we say have dementia with Lewy bodies have dementia before any motor Parkinsonism. Okay. I want to spend the last part of our time sharing with you some of what actually people in this room have taught me. Some of you are people that have seen me as patients. By the way, I won't acknowledge that fact in this room, so don't think I'm rude when I walk past you and I'm not even paying attention. But I've learned a lot about, well, what seems to help? What kinds of coping skills or responses have families and patients tried that worked? And so I wanted to share some of these points of view. And the first point of view is that no one point of view is always right. one thing I've certainly seen is every patient turns out to be a little different. And the things that seem to work best for patient 1 do not work best for patient 2. So this could be frustrating for you. You read a book or you go to a meeting and they say, do this. And you go home and you do this. And this doesn't work. Well, I'm trying to say that's not surprising. You have to recognize that not only each patient, but each day is a new case study. So one key to responding to these kinds of diseases and these sets of problems is to be open to what that day brings and open to new things to try. But in doing that, you have to realize that you have to be the driver of this boat. Who remembers Barry Goldwater? Oh, it's so nice to be in a room with people who remember things. You know, the older I get, the more medical students look younger and younger, and even residents. And I tell stories about stuff, and they look at me with these glazed looks, and they've never heard of these people. So Barry Goldwater, the senator from Arizona, was being interviewed on an anniversary of the Watergate crisis. And there was a stage during Watergate where Goldwater and some other senior senators went to the White House to talk with Nixon and say, listen, you know, this isn't going to go well. We're probably going to be impeaching you unless you resign. And he was talking as he remembered this, and Goldwater had a great way of, he was a very simple-spoken kind of guy. And he was commenting on this TV special how Nixon was trying to look very cool and relaxed, and says, Goldwater, you never think that this guy had a tail caught in his crack. A tail, yeah, caught in the crack. You get the point. I thought, what a great phrase. What a great phrase. But it's a very metaphorical phrase. You know, if you're a rat or you're an animal with a tail and your tail is caught in a crack, that's a big deal. I mean, they really go berserk. They don't like that. Don't grab an animal by its tail. So what I'm trying to get across here is, as much as there are a lot of people who care about you, some of them are paid to do that, physicians, nurses, social workers, and so on, but others, family and friends, in the end, you have to be the one, the patient, the caregiver, you have to be the one that makes things happen. You can't wait for the world to come and scoop you up. And the people I've seen do best have that kind of can-do attitude. Not necessarily, you know, militant or argumentative, but just, gosh, I'm going to do what I can. And that's an important thing, to be able to do all the things that can be done. And you cannot do it alone. To quote a phrase, it takes a village. If a patient has reached a point with cognitive impairment that they really shouldn't be alone, that doesn't mean that there's one person that always has, the same person has to be all the time. If you know 7 people, then each of the 7 can take a turn. That's their day to be with that person. If you know 21, then someone can do it once every 3 weeks. You need a team of people. You need physicians. You need nurses. You need caregivers. You need social workers. You need support groups. You need friends. You need family. You need a team to be able to respond to some of these problems. And when you're doing that, you need to talk about this. Occasionally I have situations where a family says, don't tell mom your diagnosis. And I almost always refuse to comply with that. I think that's wrong. And I encourage people to talk with their family and friends about their disease, about some of the burdens it creates. Part of the reason that groups like this are useful is you realize you're not in it alone. And you realize that, gosh, this person has tried something, I hadn't thought about that. Maybe that is something I could try too. Or I didn't know this thing could be done. Or I didn't know that I was so much better than some. Or that, gosh, I didn't realize I was suffering so much from this one thing. Maybe I can do something about it. You need to talk. You need to learn. You need to acquire as much knowledge as you can about not just what's the cause of these diseases, but what kinds of things do people do to respond. Don't make perfect the enemy of better. movie I watched years ago called Wag the Dog. Remember this movie? Good movie. And it's Robert De Niro plays a fix-it man for politicians. And a politician has gotten himself in trouble, and he's going to come and distract the public with a different news story. And he's getting everyone together. So, okay, guys, we've got to come up with a plan. He says, a good plan today is better than a great plan tomorrow. I thought that's a great phrase. And it's really true. These are not fun problems. Parkinson's disease is challenging. I get it. You don't want to be experiencing it. But the path in front of you is either the path you're on now that's not good, or a path that's better than that. Everyone wants a path where it all goes away, but that path may not be there. So if you've got a path in front of you that's a better path, take it. Take better. You don't have to wait for perfect. Particularly as cognitive problems occur and forgetfulness becomes an issue, it's really important to have routines. Every day you have breakfast at the same time and lunch at the same time and dinner at the same time, and you get up at the same time and you go to bed at the same time, and you wear the green shirt like Mr. Rogers. He comes in and wears the sweater to talk to people and a different outfit to leave, then go talk to the mailman and so on. You want to have routines. The routines become the scaffolding on which you can hang the rest of your everyday activities. The routines remember for you that it's time to do this or time to do that. They become guideposts to everyday life, so there's less to figure out. And since a big part of the cognitive changes in Parkinsonism is that movements and thinking become slow, take a hint. Go slow. It's important to recognize that there are many aspects of the brain that may still work reasonably well or very, very well. So look for those. I remember a lady who brought her husband to see me many years ago who was in an advanced state of dementia, lived in a nursing home, and was mute. He could barely walk into the office as she brought it in to discuss some issue in his pajamas that he wore at the nursing home. Said nothing. Wouldn't respond. And in talking with them, the wife told me that he was once a very fine musician. And music had been an important thing in their lives, and in fact, he can still sing. Really, says I? Can you show me? She says, sure. She said, honey, let's sing the such and such song. And she starts to hum, and she starts to sing, and a little twinkle comes in his eye, and he starts to sing with her, and he's snapping his fingers, up, ba da da ba da da ba da da, two-part harmony, all kinds of things. He still was able to do that. That's a little island of preserved humanity in him. Another patient I'm thinking of who also has severe dementia, who also can't even walk on her own, comes to clinic in a wheelchair, doesn't verbalize, doesn't respond when you talk to her, and still at home, her husband takes care of her. But when he turns on the Andy Griffith Show, remember the old Andy Griffith Show? She laughs, especially at Barney, which I think is great. I mean, if that's all I have left, that's pretty good. I like the Andy Griffith Show. You have to search for these islands of preserved humanity. I get that this is sad. I get that you would rather have all of the person's humanity. But don't miss out on this. This is what there is to do. Don't miss it. And you have to be kind of ruthlessly practical. If whatever you're trying doesn't seem to work well, you may have to shift. If you're doing something that works, great. If not, be practical. You have to shift. Another way to put this is, you have to focus on outcomes. So often, people get stuck on, well, I think this idea should work. Here's a process, here's an idea that ought to work. Honey, you have to get up and use the bathroom. Remember the doctor said you have to use the bathroom a lot? That may not work. A wife told me that she had exactly that problem. Her husband had to use the bathroom often, otherwise there would be some issues. But he wouldn't do it. And when she tried to explain it to him, it didn't help. That process didn't work. But then she discovered just by accident one day that if he happened to be up and walking and walked down the hallway past the open bathroom door, he would go and use the bathroom. So what do you care about? Do you care about that he agrees to my instruction, or do you care that he goes to the bathroom? It's the latter, right? So she just found ways to make sure that when he was walking, she kind of got in the way and stood in the thing so he'd have to go the other direction. He would walk by the door and use the bathroom. It worked perfect. So you have to focus on outcomes. Now, there are a lot of data now that a lot of this is just stuff your mother would have told you. Eat well, get good sleep, don't mess around with the wrong people. Good sleep makes a huge difference. So it's important to follow the concept is sleep hygiene. You go to bed not with the television on, lots of reading and popcorn and all kinds of things. The bedroom is for sleeping. It's quiet, it's dark. You go to bed at a reasonable time. You get a reasonable amount of sleep each night. The room is comfortable, so on and so on. Nutrition also. These days I'm starting to recommend that people eat a diet rich in fresh fruits and fresh vegetables. Some people argue there's different data to argue for the idea of this, what's called the Mediterranean diet. I told my wife once we should do the Mediterranean diet, so she ordered a pizza. And I said, wait a minute. And I mentioned depression before, but really depression is so treatable. There are all kinds of medications that at least make a dent in depression. I think particularly in the Parkinsonian diseases, it's very important, I think, to look for it and be aggressive in treating depression. So many things dovetail with depression that if treated, there are a lot of symptoms that can get better. This is a phrase I use all the time. If a patient is very forgetful, in a sense, the problem is not they're forgetful. The problem is what it's being allowed to do. Memory loss is not the problem. The problem is what it's allowed to do. So if a person needs to there's something important, and if that important thing depends on the person's memory, and they've got bad memory, then that important thing is at risk. You can't do that. What you might want to do instead is, this is Ronald Reagan's line, trust with verification. When Reagan and Gorbachev were negotiating to get rid of nuclear weapons, they had a press conference in one of those earlier meetings at the White House, and President Reagan said, well, ladies and gentlemen, I'm pleased to say we're going to reduce the weapons, and we've agreed we're going to have trust with verification. It's a perfect politician's line. We're going to trust that they're getting rid of their weapons. In addition to that trust, we're going to go find out. So it's a common issue. Well, Mrs. Jones, are you taking your pills? Well, I must be. Well, how do we know? A person who's forgetful can't be in charge of things that are important. They can participate, but some way there has to be some process of verification. That's how people stay safe. And it's use it or lose it. By being cognitively active and by being physically active, you can better hold on to cognitive function and motor function. But it's important to understand, for those of you who are working as caregivers, that you're the stranger in the foreign land that the patient is in. You know, Americans are often accused of being, the ugly Americans when we travel because we comment on how in France, this isn't the way you should do things. And we're in Taiwan, well, how come you drive this way? It's their country. You have to figure out what they're going through. So it is not the case that you should try to make the patient more like yourself. A corollary to this is you really can't impose your reality on the other person. I remember a patient, in this case it was Alzheimer's disease, and the patient had been diagnosed with Alzheimer's disease, and I got a call a few weeks later, can we come back and talk? And the husband was explaining, she's angry at me all the time. I'm just trying to keep her connected to reality. And every time she made a mistake, he said, well, no, honey, it's not Tuesday, it's Wednesday. Or no, honey, we actually went to the bank yesterday. We don't have to do it again. And it turns out she didn't like that. Some of that's, husband and wife stuff. But it illustrated for me, and I hadn't really thought about it, he was trying to keep her, he used that phrase, trying to keep her connected to reality. And the problem is you really can't. What you have to do is to crawl inside their reality. And within the reality that the patient is experiencing, you can have a conversation. There are things you can say and do with each other. And that can sometimes still be a very happy place. And you can help them navigate their reality, armed with the insights from your reality, so that they stay safe. So you should avoid, therefore, correcting. It generally doesn't go well. You could try it, but take a hint. It's not likely to go well. And when it doesn't, move on. And if you have to battle, pick the right ones. Pick your battles. Driving is often one where you may need to put your foot down because it's too much of a potential safety risk, not just to the patient, but society. Medications, high finance. There are certain things where you may have to take a stronger stand. And in the end, you have to recognize that if you're trying to help a person with this kind of set of symptoms, you may not get recognized. You may not get appreciated. You may not do well if you ask the person to agree. You may have to seek forgiveness or not even get that. When I was a kid, I was the oldest of three, and I think when I was about 8 years old, I informed my parents that we were going to go trick-or-treating on Halloween without them. We were big enough now we could do it all by ourselves. And so I took my brother and sister, and we went trick-or-treating on the dead-end street that we lived on for a block or two, came back with a bag full of candy, and we did that for several years and no longer with the parents with us. Felt like a big boy. And I was in college when I found out that my dad was watching us the whole time. He was just 20, 30 feet back, hiding behind bushes or something. And the point, of course, was what he needed was not for us to agree or even to know. He just needed for us to be safe. That's kind of what a caregiver is trying to do. You need to make sure that the person you care about is doing as well as they can, that they're safe, that they're happy, they're functional. The goal is to do that. The goal is not to be thanked for it or to be recognized. And sometimes the care you're giving has to be something that the caregiver has to decide whether the patient who's benefiting even knows. Okay, so we've talked a lot about why it is that non-motor symptoms occur in Parkinson's disease. We've talked about what kinds of problems can occur and a little bit about the things that have helped. I hope some of these ideas are things you can put into action right now. These are perspectives that will not always work, but I've often seen work, and you can try them even today. Thanks.